I'm Anne Woolfield.
I'm Carla Pecoraro.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound Podcast, bringing you up-to-date information in all things O&G. Over the past few weeks, we've been talking all about caesarean sections, so it seems only fitting that this week we discuss VBAC, otherwise known as vaginal birth after caesarean section.
After a woman has a caesarean section, she has a choice about how she wants to deliver her next baby: elective repeat caesarean section or try for a VBAC. Both options have pros and cons, and our job is to help provide information and support the woman in whatever choice she makes. So why is this even an issue? Why do we need to have a discussion about VBAC at all? I mean, shouldn't a vaginal birth after a caesarean section be a standard option?
The main reason we need to talk about VBAC is because of the possibility of uterine rupture. Now, this complication is rare, but it can have significant implications for the mother and baby, which is why we need to have a conversation about it. Uterine rupture occurs when there's disruption of the uterine muscles extending through the uterine serosa or extending into the bladder or broad ligament. This is slightly different to uterine dehiscence, which is the disruption of the uterine muscle with intact uterine serosa.
Now, uterine ruptures can happen in any pregnancy, even if you haven't had a caesarean before, with an incidence of 0.5 to 2 per 100,000 pregnancies. But the risk of uterine rupture is increased in women who have had a previous caesarean section. Ranscock quotes the rate of uterine rupture as 5 to 7 per 1,000 attempts at VBAC, which is about 1 in 200. That rate rises to about 1 in 80 to 1 in 100 with the use of oxytocin. The frequency of uterine rupture is further increased depending on the type of uterine incision. The current Ranscock guideline quotes a uterine rupture risk of 2 to 9% with previous classical caesarean, 2% with inverted T or J incisions, and 2% with a low vertical incision.
Okay, so I understand the mechanism of a uterine rupture after a Caesar. You've essentially got a weak spot on the uterus which can rupture under tension, like with a contraction. But I didn't realise you could rupture without a uterine scar. Who else is at risk of a uterine rupture?
A uterine rupture can happen in any pregnancy, but there are a few at-risk groups aside from those women who've had a previous caesarean section. These include grand multis, a multiparous woman with obstructed labour and use of oxytocin, women with a cerclage who present in labour, and those with previous myometrial surgery.
Ah, okay. I always wondered why we use caution when using oxytocin in multis, and why it's important to exclude obstructed labour before doing so.
One of my colleagues was saying the other day that all of the uterine ruptures that they've seen have been in multis with obstructed labour on oxytocin.
Ooh. If a uterine rupture does occur, what kind of outcomes are we looking at for mum and baby?
Uterine ruptures can be devastating for both mothers and their babies. If a uterine rupture does occur, there's a 1 in 7 chance of neonatal death or severe neonatal hypoxia, and a significant risk of the mother needing a hysterectomy. There is also a risk of significant blood loss requiring transfusion, genitourinary injury, and perinatal or maternal death.
And when do most uterine ruptures occur? Do they always happen in labour?
Most uterine ruptures, more than 90%, occur during labour, with a peak incidence at 4 to 5 centimetres dilatation. 18% occur in the second stage, and 8% are identified after delivery, usually in the workup of a PPH. But it's important to remember that a uterine rupture can actually occur at any time during the pregnancy, although it's much less likely in the absence of uterine activity.
I guess that's why we like women to come in early in labour when they're having a VBAC. If most ruptures happen in early labour, then we really want the woman to be somewhere where it can be detected and managed quickly, rather than labouring at home. And don't forget uterine rupture in your differential diagnosis when you're thinking about your 4 T's in a PPH. Uterine rupture would fall under the T for trauma. So how do we recognise if a uterine rupture is happening?
The most common feature is an abnormal CTG, which occurs in 55 to 85% of women with uterine rupture. This would usually present a sudden onset of complicated or variable or late decelerations, or a fetal bradycardia. We would also be suspicious if there was severe abdominal pain persisting between contractions, particularly if that pain is right over the previous Caesar scar. Other signs include cessation or alteration of uterine activity, abnormal vaginal bleeding or hematuria, loss of station of the presenting part, change in abdominal contour, chest pain, shoulder tip pain or sudden onset of shortness of breath, and maternal tachycardia, hypotension, shock, or fainting.
And if we suspect a uterine rupture, then we obviously need an immediately Cat 1 laparotomy to deliver the baby as soon as possible and to repair any damage that has occurred to the uterus or surrounding structures. The damage can sometimes be quite extensive, involving the bladder or the posterior uterus. The reason I'm saying a laparotomy and not a caesarean section is because if the uterus is already ruptured, then you actually don't need to make a uterine incision. The baby is usually already delivered or partially delivered into the abdominal cavity. Although I'd definitely still call it a Cat 1 Caesar so that theatre does a right setup and we're not confusing anyone.
Okay, so to summarise what we've learned so far, a uterine rupture is a full thickness rupture of the myometrium and serosa, or extension into the bladder and broad ligament. It's most common after a Caesar, but it can happen with any pregnancy. The risk of uterine rupture is about 1 in 200 after one caesarean section. This increases to 1 in 80 with the use of oxytocin and 1 in 50 with a classical caesarean section. Other women at risk of uterine rupture include grand multis, multis with obstructed labour and CINTO, women with a Cyclasian labour, and those with a previous myomectomy. Uterine rupture most commonly occurs at 4 to 5 centimetres, but can also happen before or after labour. Signs of uterine rupture include an abnormal CTG, Caesar scar pain between contractions, cessation of uterine activity, abnormal vaginal bleeding, hematuria, chest or shoulder tip pain, maternal hemodynamic shock, and loss of station of the presenting part. And if we detect a uterine rupture, we need to call a Cat 1 caesarean section.
Okay, so we've spoken a lot about uterine rupture, but it's important to remember that the vast majority of women who have a VBAC actually won't have a uterine rupture. Roughly 99.5% of women trying for a VBAC will not rupture their uterus. However, if you are in that minority of women who do have a uterine rupture as a complication, it is a massive deal, which is why we need to talk about it. Do we know how many women are actually choosing to have a VBAC versus an elective caesarean section?
The latest data from the AIHW from 2021 shows that 12% of women who've had a caesarean section for their first baby will have a vaginal birth for their second baby, and 88% will deliver by a caesarean section. Unfortunately, this data doesn't tell us how many women are choosing to trial a VBAC. Safer Care Victoria reports that up to 58% of women with one previous caesarean section will attempt a VBAC. These stats are very different in different countries, with up to 80% of those from the US choosing to have a repeat elective Caesar. And obviously the numbers are likely to vary in different hospitals and different demographics.
There's a famous quote in the literature, once a Caesar, always a Caesar, and certainly the VBAC rates in the early 1900s reflected this, with a VBAC rate of only 3%. But we've moved away from that a lot in recent years as the safety of VBAC is becoming more and more established. In fact, VBAC attempts climbed initially in the 1990s to 40 to 50% and then dropped to 10% in the early 2000s as guidelines became more cautious about the risk of uterine rupture. Nowadays, VBAC is recognised as a safe and reasonable birth choice for most women, and so the rates of VBAC are again rising.
And if a woman does choose to have a trial of labour after Caesar, how likely is she to actually go on to have a successful VBAC?
Again, success rates vary widely, but the most commonly quoted statistic is a success rate of 60 to 80%. Of those women who choose a trial of labour after Caesar, 60 to 80% will have a successful vaginal birth, which means that 20 to 40% will go on to have an emergency caesarean section. Now, this might sound like a low success rate, but when you consider that the incidence of caesarean section in primips is about 35%, then the VBAC success rate is actually quite similar to the success rate for vaginal birth in primips. Now, this is a statistic quoted in the Green Top Guidelines and the Ranscott Guidelines. However, an Australian study suggests that the VBAC success rate in Australia may be closer to 56%. It's important that hospitals know their own VBAC success rates in order to provide local data to their patient population.
And is there any way we can predict who might be more likely to have a successful VBAC?
There's no way to be 100% sure about who will have a successful VBAC and who won't. But there are some factors that are associated with the higher chance of success and some factors that are associated with the higher chance of needing an emergency caesarean. So, first, factors that increase the chance of a successful VBAC include previous safe vaginal birth, previous successful VBAC, spontaneous onset of labour, age under 40, BMI under 30, gestation under 40 weeks, estimated fetal weight under 4 kilos, and an uncomplicated pregnancy without other risk factors. Previous vaginal birth, especially successful VBAC, is the strongest predictor of success, with VBAC rates of 87 to 91% reported in that group.
Factors that decrease the chances of a successful VBAC include age over 40, BMI greater than 30, gestation over 41 weeks, short stature, fetal malpresentation, more than one previous caesarean section, a previous caesarean section for dystocia, induction of labour, fetal macrosomia greater than 4 kilos, and diabetes or hypertensive disorders. In fact, if you have a combination of a BMI greater than 30, a previous Caesar for dystocia, no previous vaginal births, and you have an induction, your chances of a successful VBAC are only about 40%. Also, if you just have a BMI greater than 40, then your success rate is only about 60%.
Ooh, and there is a VBAC calculator available online that can help calculate a woman's individual chances of having a successful VBAC. It uses parameters like maternal age, BMI, previous vaginal deliveries, previous VBAC, and indication for previous Caesar, as well as the presence of chronic hypertension. It's quite easy to use, and it can be helpful with counselling. It's based off data derived from the Maternal Fetal Medicine Unit's Caesarean Registry, which included over 11,000 women, and apparently has been validated. There's also an Australian-based VBAC calculator, which was derived from 22,000 women and is available at vbaccalculator.com.
It's also important to talk about contraindications to VBAC. There are certainly some circumstances where the risk of rupture is significantly increased, and in these situations we would strongly advise against a VBAC. Contraindications to VBAC include a previous uterine rupture. These women have a greater than 5% risk of recurrence, or put another way, a 1 in 20 chance of another uterine rupture. A previous classical caesarean, remember the rates of uterine rupture in this group are quoted between 2 to 10%. Any of the uterine ruptures I've seen pre-labour have all been in women who've had previous classical caesareans. Where there's already other contraindications to vaginal birth, for example, malpresentation or placenta previa, and previous myomectomy involving the uterine cavity or extensive myometrial dissection. You should also exercise caution with previous inverted T or J incision, low vertical uterine incision, significant inadvertent uterine extension, and women who've had 3 or more previous caesarean sections.
Okay, so how do we actually put this into practice? Let's say I'm in the antenatal clinic and I'm asked to see Larissa. Larissa is a G2P1 at 32 weeks gestation, and she's had 1 previous caesarean section. She wants to consider a VBAC for this pregnancy, but she'd like to know some more information. How do we approach this consultation?
Well, firstly, we want to explore Larissa's circumstances and particularly have a look at her birth records for her previous pregnancy. What was the indication for the first caesarean? As we mentioned before, if the Caesar was for fetal distress, then Larissa is much more likely to have a successful birth than if the Caesar was for dystocia. What happened in the operation? Was it a straightforward lower segment caesarean section? Or did she need a classical caesarean or an inverted T or J, which would significantly increase the risk of uterine rupture? And how long ago was the Caesar? Ideally, we want an interdelivery interval of 18 months. An interpregnancy interval, which is the time of caesarean section to conception of the next pregnancy, of less than 12 months, is associated with an increased risk of uterine rupture, placenta previa, placental abruption, and preterm birth. A short interpregnancy interval is not in itself a contraindication to VBAC, but women need to be informed of the increased risk of uterine rupture.
Next, we need to review this current pregnancy. Where is the placenta? If the placenta is anterior and low in a patient with a previous Caesar, then we need to be attuned to the possibility of placenta accreta. If we suspect this, then we should arrange for further imaging, typically an MFM ultrasound or even an MRI. We also want to know some basic details like age, BMI, any pregnancy complications, and an estimated fetal weight if available. Now, just note we don't routinely arrange growth scans just because someone's considering a VBAC, but if she was having a scan for another reason, then the information can be useful. For example, if she's had an emergency Caesar for labour dystocia in the previous pregnancy, then if the estimated fetal weight of this baby is larger than the first baby, her chances of a successful VBAC are going to be reduced. For patients with no previous vaginal birth and an estimated fetal weight of 4 kilos, the success rate of VBAC drops to less than 50%, and the risk of uterine rupture is also increased.
Okay, so we've explored the current pregnancy, looked at the birth records for the previous pregnancy, made sure the placenta is clear, and excluded any contraindications to VBAC. With that information, we should be able to calculate the chances of a successful VBAC and discuss that with our patient. Now we need to have a chat about the risks and benefits of a trial of labour after Caesar versus the risks and benefits of an elective Caesar. It's important to present all of the information so Larissa can make an informed choice. Let's start with VBAC.
As with everything in obstetrics, we can divide these up into maternal benefits and neonatal benefits. The maternal benefits of a trial of VBAC include a 60 to 80% success rate of having a vaginal birth, less maternal morbidity for this and future pregnancies, avoidance of major surgery and the need for multiple caesareans in future pregnancies. Remember, one successful VBAC increases the likelihood of future vaginal births. Earlier mobilization, shorter length of stay and shorter recovery, and higher patient satisfaction if their goal is to achieve a vaginal birth, and also reduced rates of DVT. The benefits for the baby include improved gut microbiota, which is linked with a reduced risk of allergies, reduced transient respiratory morbidity, and increased maternal-fetal bonding.
Now let's discuss the risks. Remember, there are pros and cons to everything. The maternal risks of VBAC include uterine rupture, like we've already said, typically quoted at a rate of 1 in 200 or 5 to 7 in 1,000. If a uterine rupture occurs, there's a 1 in 7 chance of a neonatal death, severe hypoxia, or of mum requiring a hysterectomy. A 20 to 40% risk of an emergency Caesar, which carries a higher rate of complications than an elective Caesar. And then there's the general risks of vaginal birth. Risk of pelvic floor trauma, 5% risk of oasis, risk of that was if this is a first vaginal birth, and risk of instrumental delivery, about 40%. The fetal risks of VBAC include an increased risk of stillbirth compared to elective Caesar at 39 weeks, 1.8 in 1,000 pregnancies. Now, this is mainly due to a background increased risk of stillbirth after 39 weeks gestation, rather than actually just people having a VBAC. The remainder of the fetal risks of VBAC are typically related to uterine rupture, so these include intrapartum death or neonatal death, 0.25% increased risk of perinatal mortality, 0.08% risk of HIE, which is hypoxic ischemic encephalopathy, and of course there are the general risks to the baby of a vaginal birth, including fetal trauma, shoulder dystocia, brachial plexus injury, and fracture.
So obviously we have to compare the risks and benefits of a VBAC to the risks and benefits of an elective repeat Caesar at 39 weeks.
Again, these can be divided into maternal and fetal risks and benefits. The maternal benefits of an elective Caesar include reduced maternal risks associated with emergency Caesar. It avoids perineal trauma and associated urinary problems, the convenience of a planned date of birth, reduced risk of scar rupture, and the option for tubal ligation if fertility is not desired. Fetal benefits include avoiding late stillbirth, and as Anne said, this is purely because the rate of stillbirth is lowest at 39 weeks gestation, not because a Caesar itself lowers the risk of stillbirth, and remembering that risk is still incredibly low at 1.8 per 1,000. Reduced perinatal morbidity and mortality from HIE related to labour, delivery, and scar rupture, and reduced risk of traumatic fetal injury from birth. The risk of fetal injury at elective caesarean section is 5 in 1,000, with the majority, over 71%, being just a superficial skin laceration. The risk of fetal intracranial injury is also lowest at caesarean section, as is the risk of brachial plexus injury from shoulder dystocia.
And the maternal risks: longer recovery and length of stay in hospital, recommendation for repeat caesarean in the future, an increased risk of placenta previa and accreta in subsequent pregnancies which may require a caesarean hysterectomy, surgical complications including bleeding, infection, hysterectomy, an increased risk of complications in subsequent pregnancies. The fetal risks include lower rates of initiating breastfeeding, fetal injury of 1 in 200, again, mostly superficial, and an increased risk of TTN, surfactant deficiency, and pulmonary hypertension, although after 40 weeks there's no difference in this incidence.
Now, obviously, this is a lot of information to take in. It can be really helpful to provide women with a written information leaflet which outlines the risks and benefits of both elective Caesar and VBAC. It's also important to have this discussion in the context of the woman's individual circumstances, including her personal motivation and preferences for mode of delivery, her attitudes towards the risks of rare but serious adverse outcomes, her plans for future pregnancies, and her chances of a successful VBAC. So, back to Larissa. Larissa is given some written information on VBAC versus elective caesarean section, and she's had some time to consider her options and ask questions. She decides she wants to go ahead with a VBAC, or a trial of labour after Caesar. TOLAC, or trial of labour after Caesar, is probably the more appropriate terminology, since we can't guarantee that a trial of labour after a Caesar will actually lead to a vaginal birth. Are there any special considerations we need to have for Larissa's labour?
So ideally, you would aim for spontaneous labour, since the use of oxytocin increases the risk of uterine rupture, and the highest chance of success for a trial of labour after caesarean section comes with spontaneous onset of labour. However, it's not always possible to await spontaneous labour, as there are some circumstances where an induction of labour might be recommended for the safety of the mother or the baby. It's important to have a discussion with Larissa early about what her preferences might be if an induction is indicated. There's an increased risk of uterine rupture with oxytocin used in induction, which is, as we've said before, quoted at about 1 in 80 to 1 in 100. Induction is also associated with high rates of failed VBAC. If that risk is acceptable to Larissa, then it's reasonable to proceed with an induction. However, if Larissa is uncomfortable with that risk profile, then she may choose to have an elective caesarean instead of an induction.
If we are going ahead with an induction of labour, it's important to consider previous caesarean section in our method of induction. For cervical ripening, prostaglandins are known to increase the risk of uterine rupture compared to mechanical methods. For this reason, we would recommend mechanical cervical ripening with a balloon catheter or a Foley's. One study demonstrated rates of uterine rupture of 1.4 to 2.45% when labour had been induced with prostaglandins. That's not to say that prostaglandins are absolutely contraindicated, just that if they are used, they're being used against the manufacturer's instructions and should only be used in certain clinical situations after obtaining informed consent from the woman. We also know that oxytocin use is associated with an increased risk of uterine rupture, and so some women might choose to delay the onset of oxytocin after their ARM in the hopes that their contractions might start spontaneously. Typically, some facilities might offer a delay of 2 to 4 hours after ARM to allow contractions to establish prior to starting syntocinon. Remember, the use of oxytocin almost doubles the risk of uterine rupture, and induction of labour is less likely to result in VBAC than spontaneous labour. Some women may be uncomfortable with the risk and therefore might choose a trial of labour in the event of spontaneous labour or a caesarean section if an induction is required.
It's also important to differentiate the use of oxytocin for induction and the use of oxytocin for augmentation. Ranscock recommends that augmentation for lack of progress in labour for a planned VBAC should involve a discussion with an obstetrician and the risks and benefits discussed with the patient. Augmenting a VBAC is associated with an increased risk of uterine rupture, especially in the case of obstructed labour, but a decreased risk of needing a caesarean section. If you're considering VBAC augmentation, then you really want a thorough assessment of why there's a lack of progress in labour. If the reason is inadequate contractions, then oxytocin might be useful, but it's important to exclude obstructed labour, fetal malpresentation, CPD, and rupture first. One Australian study demonstrated a 14 times difference in the odds ratio for uterine rupture in planned VBAC patients with spontaneous labour versus those augmented with oxytocin. The total rate was 1.9% of rupture, although the odds ratio in various studies ranged from 2.3 to 14.
That's a good point about assessing why you're augmenting, because remember, one of the signs of uterine rupture is an alteration to contraction. So if you've got someone who's labouring along normally and they're contracting well and suddenly they're not contracting well, you really need to consider why before you just throw Synto in the mix there.
Absolutely. Always think it in the back of your mind. And the moral of the story is that you can augment a VBAC, but you need to be cautious about it. You need to be especially cautious with the rate of Synto. One study demonstrated a uterine rupture rate of 2.07% with Synto doses of 21 to 30 milliunits per minute.
And I would definitely involve your consultant.
Always.
Always. Our next recommendation is to have a cannula in labour. This is because in the event of an emergency, like a uterine rupture, the patient would need urgent fluid resuscitation and transfer to theatre. If a woman chooses to not have a cannula in labour, then she should be informed that inserting a cannula in an emergency can lead to multiple missed attempts at cannulation and delay in administering treatment. Interestingly, the NICE clinical guidelines and also the Queensland clinical guidelines suggest that routine siting of a cannula for VBAC is not required unless difficult cannulation is anticipated or there are additional risk factors. However, the RANZCOG guidelines and several other hospital guidelines still support the recommendation for a cannula in labour. We also recommend a CTG in labour. The reason for this is that an abnormal CTG may be one of the earliest signs that a uterine rupture is occurring.
Yeah, it's interesting that the Queensland guidelines don't suggest having a cannula in. But if you work in a small unit and there's not many people inside and you have a uterine rupture, you don't really have the manpower to waste by putting someone's cannula in. I think that's why you really
clinical judgment.
Yeah, and every Queensland hospital I've worked at has had a cannula in labour for VBAC.
Yeah, I know. Yeah, same. Yeah. Interestingly, the NICE guideline changed their recommendation for management of labour with vaginal birth after VBAC in 2019. The guideline initially said that an IVC and CTG monitoring are not required, but they've subsequently changed their recommendation back again to recommend a CTG. I mean, it makes sense since that the earliest sign of uterine rupture is fetal distress. Having a CTG would allow uterine rupture to be detected in a timely manner, and having a cannula would allow for rapid maternal resuscitation and delivery in the event that a uterine rupture occurred.
Oral intake should be restricted to clear fluids because of the greater than normal probability of needing an immediate Caesar under GA. Other recommendations from the RANZCOG guideline include 4-hourly vaginal examinations in the active phase of labour and more frequently as full dilatation approaches. 2-hourly assessments from 7 centimetres dilatation can help to detect a secondary arrest of labour. Now, these are important because you really want to detect obstructed labour early because if you persist in labour with obstruction, you are much more likely to lead to a rupture.
So then what about the management of early labour? What should we be telling these women when they ring up the maternity assessment unit or birth suite and let us know they're contracting regularly?
I would recommend that patients attend hospital at the onset of contractions. As we mentioned before, the highest risk of rupture is at 4 to 5 centimetres, so we really want these women to come in so we can monitor them with a CTG. RANZCOG recommends that women should be advised to have continuous electronic fetal monitoring following the onset of uterine contractions and for the duration of the planned VBAC. If a uterine rupture does happen, then we want to diagnose it early and provide an urgent caesarean section and resuscitation for both mother and baby.
Okay, so to summarise the key points of our VBAC consultation. Review previous operative notes and the indication for delivery. Exclude contraindications to VBAC. Identify current placental location and their risk of accretor. Determine future pregnancy plans and their motivations for either a VBAC or caesarean section. I like to ask women how many babies they're planning on having as well, to see how many Caesars they would have in the future. Review obstetric and medical history. Use a VBAC calculator to provide individualised counselling on VBAC success rates. Discuss the risks and benefits of both a VBAC and elective Caesar and provide written information on this. Discuss management plan if a patient wants a Caesar but presents in labour. Discuss a management plan if the patient wants a VBAC but needs an induction. And discuss intrapartum management. Recommend to present early in labour, there's a cannula in labour, and continuous CTG monitoring.
Yeah, you might remember from our previous episode that we said that 10% of booked elective caesareans at 39 weeks will present in labour beforehand on Anne's night shifts.
Yes, definitely.
And it did happen. Okay, so let's do a bit of troubleshooting here. What about if we can't find the notes from the previous Caesar? It was done overseas or it's back on paper records from 20 years ago.
So this can be tricky. I mean, if you can't see the op notes, then how do you know they didn't have a classical caesarean section or an inverted T or a J or some other contraindication? Well, you'd be forgiven for thinking that the safest option here is to recommend an elective repeat caesarean, since you can't technically exclude any contraindications to VBAC. However, there actually have been a few studies looking into the rates of uterine rupture in those with a known prior low transverse uterine incision versus those with an unknown type of uterine incision. And guess what? The rupture rate is actually the same. ACOG and UpToDate both suggest that if you don't know where the prior uterine incision was, then you can reasonably assume that it was a lower segment transverse incision, since the vast majority of patients with a previous caesarean will have had that incision type. Obviously, if the patient had a preterm Caesar or has a known lower segment fibroid or was told that she is not suitable for VBAC, then we would have a higher suspicion that the prior uterine incision might have been made into the upper segment of the uterus, in which case we would not recommend a VBAC.
What about single versus double layer uterine closure? Does that matter?
It's long been thought that a single layer closure has a higher rate of uterine rupture. However, this has not been shown to be true in studies. A retrospective Danish cohort study of 7,600 patients found no association between single-layer closure and uterine rupture when compared with double-layer closure. These findings are also consistent with a prior meta-analysis. Therefore, a single-layer uterine closure is not a contraindication to VBAC. Ranscock states that there is conflicting evidence as to whether a single layer compared to a double-layer closure increases the risk of scar rupture.
I also remember from our previous episode on the evidence-based caesarean section that a single layer closure resulted in a reduced myometrial thickness compared to a double layer closure. So why don't we just measure the myometrial thickness to assess the risk of uterine rupture?
Unfortunately, ultrasound measurement of myometrial thickness has not been demonstrated to be sufficiently predictive or protective of uterine rupture to be useful in clinical practice. While it seems logical that a thinner scar would have an increased risk of rupture, we don't actually have enough data to say what a safe myometrial thickness is. A thin myometrium actually has a low positive predictive value for rupture, and patients with normal lower uterine segment thickness have gone on to rupture their uterus when in labour. Despite the limitations in evidence, some clinicians consider a lower segment thickness of less than 2 millimeters to be predictive of an increased risk of rupture and incorporate this into clinical counselling overseas. Australia does not seem to use myometrial thickness in antenatal counselling.
And will an epidural mask a uterine rupture?
Essentially, no. There's no evidence that an epidural masks uterine rupture, or that it increases the risk of uterine rupture or failed VBAC. In fact, an epidural may even be helpful in the event of a uterine rupture, since it can facilitate a faster caesarean section. The Queensland Clinical Guidelines state that an epidural use during attempted VBAC is associated with higher rates of VBAC, higher rates of instrumental birth, and similar rates of uterine rupture. Women should be allowed to utilise whichever pain management options they desire.
Okay, and then what about if we have twins?
So Ranscock states that a cautious approach is advocated in twin pregnancies who are considering VBAC. However, this guideline was published in March 2019. A subsequent meta-analysis published in May 2019 showed no increased risk of uterine rupture, hemorrhage, morbidity, or neonatal mortality compared to singleton VBAC. The pooled success rate was 72.2%, and the rate of uterine rupture was 0.87%. Therefore, twins should not be considered a contraindication to VBAC. This view is also supported by the Queensland Clinical Guidelines.
And what about a water birth or water immersion?
A previous caesarean section is not a contraindication to water immersion, provided there's adequate fetal monitoring. Although keep in mind that every hospital has their own policy on water immersion and water birth, and so it's important to follow your local hospital guidelines, which is designed to keep both mums and bubs safe.
What about if you've had more than one Caesar?
So the main concern with attempting a VBAC after 2 previous caesarean sections, or a VBAC 2, is lower success rates, higher rates of uterine rupture, and increased maternal morbidity compared to a VBAC 1. Queensland Clinical Guidelines suggest that VBAC 2 is a reasonable option for women with a history of 2 or more prior caesarean sections following counselling with an experienced obstetrician. This is based on a systematic review that reported a VBAC rate of 71% compared with 77% for VBAC 1, a uterine rupture rate of 1.36%, and the fact that maternal morbidity for women undergoing a VBAC 2 is actually similar to that of women undergoing their 3rd caesarean section. There were no significant differences in neonatal morbidity, although the data was too limited to draw valid conclusions. Counselling and situation of a VBAC too should definitely still be individualised.
It's also really important to consider the service capabilities of the birthing facility when having discussions about VBAC, especially in those cases where there is a higher chance of uterine rupture. Ideally, you need access to an emergency theatre for caesarean, a blood bank, and skilled staff in the event of a uterine rupture. A VBAC in a tertiary centre is likely to be much safer than a VBAC in a rural Australia where there's no access to emergency theatre, for example. For these reasons, different hospitals may have different guidelines on what they consider to be acceptable and safe. Some hospitals might deem their facilities inadequate to support a VBAC1, for example. These guidelines are there for a reason, and it's important that you follow your local hospital guidelines.
Okay, folks, well, that wraps up this week's episode on VBAC. You'll find our study notes up on Instagram later in the week. If you have any feedback or opinions on anything we've discussed today, please contact us through our Instagram at the Uterine Sound or on Facebook, or email us at theuterinesound@gmail.com.